Good afternoon, I'm Dr. Rutledge, and I'm going to be talking today about the mini-gastric bypass, as usual, but also some kind of misunderstandings about the RNY gastric bypass and the differences in the two. And we're particularly going to be focusing on malabsorption of fat and the misunderstandings about the RNY being more malabsorptive than it actually is. Most people, when they talk about it, recognize that it's primarily a restrictive procedure, but then because it's a bypass, there's discussions about fat malabsorption. And there's not much thinking about the fact that it is basically causes no malabsorption of carbohydrate and protein. So we're going to go through that a little bit today, talk about it, and go through some details that what we recognize seems to be a lot of misunderstandings by good bariatric surgeons who I kind of describe it as kind of forgetting some of the basics of general surgery, GI surgery, and gastric and gastrointestinal physiology. So let's get started. We're going to talk about the RNY gastric bypass, and if you look at it, it has kind of what look like two components. There's a bypass of the duodenum where fat absorption is very critical, and particularly the upper jejunum. There's also a small gastric pouch, and many RNY surgeons, although not all, focus on a very small gastric pouch and a small gastrojejunostomy. And then when they see RNYs that fail, they intervene in some cases for revisions to narrow the pouch and narrow the gastrojejunostomy. And there's even transoral techniques to allow us to go ahead and narrow the gastrojejunostomy. And so when we look at the anatomy there, you can see that there's restriction. The restriction is through the small pouch and the small gastrojejunostomy. And then there is also evidence for bypass, and so we can talk a little bit about both of those. Malabsorption versus restriction. And so one of the things I'd like to refer to is a recent article on this topic, because a lot of surgeons, when they think about it in a general way, thinking that bypass of the duodenum is going to lead to fat malabsorption, just as kind of a common sense idea. And so it's interesting that in 2010 there was a nice article where they actually measured the malabsorption as well as some of the other physiologic changes following long-limb Roux-en-Y gastric bypass. And this is an article by Elizabeth Ostrasil and others published in the American Journal of Clinical Nutrition. And basically the idea is that the Roux-en-Y restricts food intake. And they wondered when they made a long roux limb up to 150 centimeters. The question they wanted to ask is the Roux-en-Y malabsorptive? That is to say, we know they get weight loss, and we know there's a decrease in calorie intake, but what is that from? Is the decrease in caloric intake following Roux-en-Y gastric bypass, is it secondary to restriction? Or is it secondary to malabsorption, or a little of both, and how does that break down? So the goal of this paper, which I think from my review seems to be fairly well done, is to try and quantitate the effects of the Roux-en-Y gastric bypass. And we're going to look at that in some detail. Again, the title, for those of you who want to look this up, is The Contribution of Malabsorption to the Reduction in Net Energy Absorption After Long-Limb Roux-en-Y Gastric Bypass. And it's published in 2010, the October issue of the American Journal of Clinical Nutrition. Okay, so what are the results? First of all, I want to emphasize something, and that is that the Roux-en-Y had no significant effect on protein or carbohydrate absorption. Okay, so when we say the Roux-en-Y has a malabsorptive component, we need to emphasize it has zero impact on the malabsorption of protein or carbohydrate. That is to say, no malabsorption of protein or carbohydrate in this study. They fed people a measured amount of protein and carbohydrate. 100% of fed calories into the roux limb was absorbed. 100% of protein and carbohydrate calories. So no malabsorption of protein or carbohydrate. So every bit of sugar, every bit of protein that's eaten, every bit of starch that's eaten is absorbed in the Roux-en-Y patient. Then they looked at malabsorption and restriction. Okay? So what they wanted here is that 5 months after surgery, they measured the total number of calories that the patients ate, compared that to the number of calories they ate prior to surgery, and so some of the decrease in calories that are taken in and absorbed are by the fact that the intake is decreased. So that's kind of common sense. It restricts, the Roux-en-Y restricts intake. Okay, that makes sense. And so they looked at the decrease in intake, and then of what was taken in, what amount was malabsorbed. And we already talked about that, saying that essentially 100% of protein and calories that were taken in were absorbed. So 5 months after bypass, they noticed that malabsorption, which had to be only from fat, because it did not come from malabsorption of protein or carbohydrate. So malabsorption of fat led to an overall total daily decrease in caloric intake of about 124 calories. In other words, the malabsorptive component studied at 5 months resulted in a decrease of 124 calories per day. On the other hand, restriction reduced the total caloric intake by about 2,000 calories. Okay, so let's do that again. A little over 100 calories were malabsorbed. So that is, the malabsorptive effect as far as calories was a little over 100 calories. And the restrictive effect was 2,000 calories. So the Roux-en-Y is a restrictive procedure. Primarily a restrictive procedure. Okay? The restrictive effect, that is 124 divided by 2,000, is about 16 times more important than the malabsorptive component. So there is some malabsorption, but the total malabsorptive effect at 5 months was small. At 14 months, it was within the same amount, about 170 calories on average, and restriction had now decreased. Okay, so let's think about this for a second. So Roux-en-Y is primarily a restrictive procedure. And by 14 months, a little over a year after surgery, the restriction had decreased from a total decrease of 2,000 calories to now a decrease of only 1,400 calories. So by 1 year, the restrictive effect of the small pouch and the narrow gastrojejunectomy in the Roux-en-Y is already beginning to fail. So Roux-en-Y is a restrictive procedure, and in this study, we can see the restriction beginning to fail. We also see that the impact of fat malabsorption is quite small. If we project that on a straight line, then we can see that in the future, several years out, that if that trend continues of 2,000 to 1,400, that sometime in the future it'll be down to 700 calorie impact. The fat malabsorption stays roughly the same. And that means that we can project the Roux-en-Y to fail. And the failure is simply a loss of restriction. And the malabsorptive component is small and remains, but it's very tiny, 100 plus calories a day. In other words, much less than a single soda pop or a candy bar per day. So that malabsorptive component in these studies was only between 6 and 10% of the total impact of the Roux-en-Y. So what we want to show and what we want to conclude from this study is that the Roux-en-Y is primarily restrictive, and it's particularly restrictive when studied early after the surgery. But as soon as time begins to pass, even as early as 1 year, we can already see signs that the restriction is beginning to fail. Okay. Now again, fat malabsorption, fat intake prior to bypass in these patients was about 150 grams per day. By 5 months, it was down to 50 grams. But by 14 months, the total fat intake was back up to 82 grams. So you can see the trend. Okay, now that's one of the points we wanted to get to, which is when you're thinking about an operation, whether you're a surgeon or a patient, you're saying, gee, I wonder what's best. And the Roux-en-Y is not a bad operation, but it does have some downsides. It's clearly the most dangerous operation in bariatric surgery. There's numerous studies. We could go through 100 references. We do this on some of the other videos. Basically, there's no higher death rate, complication rate, bowel obstruction rate than the Roux-en-Y. By every test and every study, Roux-en-Y always comes out to be the most complicated, the most dangerous. The most serious problems come from the Roux-en-Y gastric bypass. So it does have good weight loss, but there's a lot of studies also, including a lot of the research done by Dr. Phobie, shows it fails. That is to see you tend to fail over time. And a lot of people are not clear on whether it's restrictive or not. It's primarily a restrictive procedure, and even in the short term, you can see that the restriction begins to fail. There is a small 5 to 10% component of malabsorption of fat, but that's very small in the contribution overall, and it tends to fade over time as well. So that's a topic which I felt like was worth discussing because I think a lot of surgeons and patients are unaware of that particular set of points about the Roux-en-Y. Another area of research which I think a lot of general surgeons, gastroenterologists, and bariatric surgeons are unclear about is bile. Okay? Now, what most of us know about bile is a detergent. It's the green, caustic detergent that lives inside the gallbladder, the liver, and the common bile duct and is squirted into the duodenum to help digest fatty foods. Okay, when that happens, what we notice, what we see at that time is that the fat, which is not easily digested or absorbed, is partially solubilized by the bile acids so fat can be absorbed. This fatty absorption of the fatty foods allows the absorption and the utilization of fat in the diet. You and I are mostly water, oil and water, fat and water don't mix. So a detergent like the Dawn dishwashing liquid detergent is added to the mix. And when bile is mixed with the fat is solubilized and able to be moved into the cells and then into the lymph system and be absorbed. So most of us, general surgeons, gastroenterologists, medical physicians, and patients understand that bile is a detergent that helps absorb fat. But most bariatric surgeons do not understand the most recent research that bile acids are more than just the fatty detergent that helps you absorb fat. And so the key points we want to talk about in this next section is that bile acids, when they are decreased because of the detergent effect, decrease fat absorption. So bile acids are indeed, as most of us know, important in fat absorption, and if bile acids decrease, then fat absorption will decrease. But additionally, what many surgeons don't know is that studies show that bile acids also play a very important role in glucose homeostasis. Okay, we're going to talk about those things for a few minutes. Bile acids are not just detergents. Bile acids are hormones. Again, this is relatively new, very exciting information. Bile acids act as hormones on a variety of critical receptors. The farnesoid X receptor, so-called FXR, the pregnane X receptor, PXR, the constitutive androstenedione receptor, CAR, and the G protein coupled receptor, TGR5. Bile acids as hormones regulate cholesterol, glucose, and metabolic and energy homeostasis. What most bariatric surgeons do not understand that bile acids are critical to fat and glucose control in the body. That decreased bile acids decrease fat absorption and lower blood glucose levels. And this means that the MGB, or Bile-Roth-2, decreases bile acids, and that RNY does not affect the bile acid pool. So let me do that again. Bile acids are critical factors in the absorption of fat, and they control cholesterol in the body. They also control glucose, this is relatively new, and affect insulin resistance. So a decrease in bile acids decreases fat absorption and lowers blood glucose levels. Well, the research we're going to talk about in a little bit shows that the MGB of Bile-Roth-2 type anastomosis decreases bile acids. And with a decrease in bile acids, as we said, we get decreased fat absorption and we get lower blood glucose levels and a better therapeutic effect in diabetics. The RNY specifically, as we're going to talk about, does not affect the bile acid pool, and therefore we do not get the benefits of a decreased fat absorption or lowered blood glucose levels from an effect on bile acids. So again, we go back to the study that we referenced earlier, of the long limb RNY gastric bypass, and the results in particular show the RNY does not cause bile acid malabsorption. Fecal bile acid secretion was about 0.8 grams per day pre-op, post-op 0.5 grams a day, and post-op at 14 months 0.7 grams per day. So not significantly different. So the RNY does not decrease bile acid, does not then help in the treatment of diabetes, and the RNY does not cause loss of bile, and so that mechanism is not active in the RNY. Many people think, oh, the MGB and the RNY are the same. They're both bypasses. They are not. And this is a misunderstanding of a lot of bariatric surgeons, patients, general surgeons, and gastroenterologists. Particularly important is the new research on bile and its impact on the glucose in the body. Now, again, giving you some more background on this topic, when you decrease bile acids, you can reduce glucose levels. Okay? Again, this is relatively new. Most bariatric surgeons don't know this. Most general surgeons and a lot of patients are unaware. So let me say this again. There's a way to decrease bile acids in the body relatively easily and relatively commonly, and that is giving drugs which are called bile acid sequestrants. Okay? And studies of these show that when you treat patients, particularly with certain members of this class of drugs, that you reduce plasma glucose levels in type 2 diabetics. And these bile acid sequestrants induce plasma glucose lowering by increasing the metabolic clearance rate of glucose in peripheral tissues. And again, to go back to the same point I'd like to emphasize, RNY does not cause loss of bile. The MGB does cause bile acid losses, and decreasing bile acids improves glucose homeostasis. That means it improves the therapy of diabetics. There's a lot more we can talk about on that, but I'm going to skip over that. Again, just to summarize, bile acids are hormones. Bile acids affect fat and sugar. Decreasing bile acids lower the amount of fat and cholesterol that's absorbed. Decreasing bile acids improve the therapy of diabetics. And so the MGB decreases bile acids. The Bile-Roth-2 decreases bile acids. The RNY does not. All right, we're going to go on to another topic. And this topic I'm going to start off by pointing out that bariatric surgeons, it appears to me, have often forgotten some of the history of GI surgery. And so I'd like to point out a couple of things that we've learned from GI surgery that don't appear in the thinking or the discussions of most bariatric surgeons. What have we learned in relationship to gut bypass and the Bile-Roth-2 and the RNY from the past 100 years of GI surgery? So this is not new research. This is old research that people have just forgotten about. And I'd like to point that out. For over 75 years, general surgeons, GI specialists have talked about post-gastrectomy steatorrhea. That is, for 100 years, we've been taking out parts of the stomach for various illnesses, ulcer disease most commonly, gastric cancer and other things as well. And what we found is those patients who had GI surgery often presented with a postoperative complication of fatty stools, diarrhea, fat in the stools, or so-called steatorrhea. And that they found in lots of these research studies published in the 1920s, 30s, 50s, and 60s is that malabsorption or steatorrhea was a common complication after gastrectomy. It was more common, the greater degree, with Bill Roth II than Bill Roth I. And there's numerous references on this. So what do we know? That this steatorrhea problem, this fat malabsorption problem, is rare after the Bill Roth I, and it's particularly common after a kind of Bill Roth II called a polya gastrectomy in Bill Roth II. That's where you have a wide, long, wide-open gastrojejunectomy. And this is studied back in 1961. Oh, Dr. Levins, how are you?
I know that guy from somewhere.
All right. Sorry, let me interrupt here. I'm just killing time.